Alright guys, welcome to another video. Today we are in the ER on our OB rotation. We just got sent down there for a consult. So a woman has come in. She gave birth via C-section 2 days ago. She's passed a few blood clots from her vaginal canal. This has had an odd smell associated with it, and overall she just feels like something is wrong because none of this has happened in her prior pregnancies. So we go ahead and take her vitals, and her temperature is 100.4 degrees. Other than that, she's hemodynamically stable. So what are we really worried about? What are things that could kill her? So there's a lot of reasons for a post-op fever, but given her recent history of having a C-section, there's really only one thing I'm thinking of. And so on your OB rotation, one thing you will be asked is what the most common cause of postpartum fever is. The answer to that is endometritis. So endometritis is inflammation and infection of the endometrium. When this happens in a woman who has recently given birth, we call it postpartum endometritis. The most common risk factor for this is C-section, but it can also include an operative vaginal delivery, aka instruments or devices were used, and other risk factors include IUD placement, colonization with group B strep, and so on. So symptoms that your patient will have, obviously fever. They will also have uterine tenderness and purulent lochia. So lochia is the passage of blood following birth, and it represents the shedding of the endometrium that has been kind of growing this baby for us for 9 months. Pelvic exam will show a firm but tender uterus. This is a part where if there was a different finding, you need to start considering other causes, but given this woman's history, endometritis is the most likely cause. So the treatment for this is going to be clindamycin and gentamicin. The reason for that is that endometritis is often a polymicrobial infection, so we need coverage for both gram-negatives and anaerobes. One of the ways we kind of get value when we're studying for step 2 is with integration. So we need to integrate things that we learned in, studying for step 1. We need to integrate that into step 2. And so things that they could ask going forward are what would happen as an adverse effect of clindamycin? And the answer to that would be C. diff. Some very commonly tested things are adverse effects of aminoglycoside antibiotics such as gentamicin. The two that you really need to worry about are ototoxicity and nephrotoxicity. Another thing to worry about as you get into that step 2, step 3, that higher level learning is thinking about some of the rarer side effects of gentamicin. So one of those is neuromuscular blockade. You need to watch out for patients with myasthenia gravis who were given aminoglycosides and they suddenly develop rigidity or blurred vision or difficulty breathing. The treatment for neuromuscular blockade with aminoglycosides is IV calcium. Another integration, this really won't be tested, but it's for your own personal learning, is why does gentamicin not kill anaerobes? If you think about it, aminoglycosides are really strong, very broad antibiotics, and it makes sense to wonder why they don't kill anaerobes. And the answer to that is because gentamicin only enters bacterial cells via oxygen. So the transporters that help it get into bacteria, they only work through oxygen. And so when you have anaerobic bacteria, they literally will not let this antibiotic into the cell. One other question you will be asked is how endometriitis is different from chorioamnionitis. These are two very similar things, but chorioamnionitis occurs when the baby is still in the body, not once it's left. And so you get an ascending infection that then infects the endometrium, and it also infects the amniotic fluid. So a sequelae of this will be fetal tachycardia. And so you might see that as a finding that's kind of hidden in there, but if you're looking for it, this can really help you out. So as we talked about, one of the risk factors for endometriitis is colonization with group B strep, also known as strep A galactiae. So when you're doing these prenatal visits, when do you test for GBS colonization in mom? A couple options here. First visit, 10 weeks, 28 weeks, or 36 to 38 weeks. You really will be tested on this, so you need to know this. And the answer to this is 36 to 38 weeks. You can look at this UWorld chart here. Some of the things to really know are that right around that term period, you're going to test for group B strep. Around 24 to 28 weeks, that's when you do your oral glucose tolerance test, and you check antibody if the mom was RHD negative. At your initial prenatal visit, that's pretty much when you'll do everything else, including syphilis testing. One thing to know on your OB rotation, especially if you're in the South Carolina area, is that syphilis is on the rise. You need to be testing for it. People won't volunteer this information, so you need to test for it. That's about it for this video. Thanks a lot.